Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
This episode of Big T Trauma is sponsored by Teleflex, a global provider of medical devices that address the time-critical challenges of achieving vascular access and bleeding control. Not all products are available in all regions. To learn more, visit teleflex.com.
Hello, this is Patrick Georgoff with Behind the Knife. I got a scenario for you. It's 1 a.m. Saturday morning, and a trauma arrives with a GSW to the proximal thigh, and they have no distal pulses on that leg. Who's doing the repair? Is it trauma or is it vascular? What if it's below the knee? What if it's the upper arm, the subclavian, or even the IVC? There are countless factors that play into this scenario, and this includes trauma surgeon skill and experience, whether or not a vascular surgeon is available, how stable is the patient, how complex is the injury. Is there any potential benefit from an availability of endovascular treatment? What are the institutional politics? There's so much that goes into this. So acknowledging that every patient, each institution, and any given night on call is unique, there is concern among the surgical community that the bulk of the responsibility for addressing traumatic vascular injury has shifted towards the vascular surgeon. So why is this? And should we in the trauma surgery community care? Certainly we care, so we can dive in and talk about this a little more. So to help us get through this, we've got the Big T Trauma co-host, Dr. Teddy Puzio, who's a trauma surgeon at University of Texas in Houston. We've got a new guest, Dr. Brian Gilmore. He's a vascular surgeon at Duke and associate PD of our integrated vascular surgery residency. And another new guest, Dr. Joe DuBose, who is professor of surgery at the University of Texas in Austin, where he's director of the Integrated Trauma Research Group and director of vascular resuscitation and trauma management. Joe has particularly unique insight into this topic because he's dual trained in both trauma and vascular surgery. Dr. DuBose is also a retired colonel in the U.S. Air Force. He retired in 2021 after 20 years of active duty. Joe, thank you for your service. Let's get right back into this issue. So again, we have this GSW to the proximal thigh, no distal pulses. It's 1 a.m. Saturday morning. Let's go down the board here. Teddy, starting UT Houston, who takes this patient to the OR?
Trauma.
Okay. Joe, University of Texas in Austin.
A little convoluted. We have two dual trained people here who take trauma calls. So it may be a vascular surgeon who does it, but I'm in trauma duties. And I think that's the person who's at bedside when the patient arrives. It's inherent if you're going to move emergently that the trauma surgeon's there, the vascular surgeon has to come from home.
Great. Brian?
Like Joe said, it does get a little bit complicated and convoluted. So I'd say it depends on the presence of other injuries and how stable or unstable a patient might be.
Yeah, it all depends, right? I think there's something that's really interesting that a lot of surgeons may not know, both on the vascular and the trauma side, that the American College of Surgeons does not require that level 1 or 2 trauma centers have a board certified or board eligible, for that matter, vascular surgeon available. Instead, they state that the trauma centers must, quote, have continuous availability of vascular expertise. So contrast that with orthopedic and neurosurgery, where level 1 and 2 trauma centers are required to have board certified liaisons. Dr. DuBose, that raises the question of who determines vascular expertise and what are these standards then that trauma centers need to uphold?
Yeah, it's a great question because the expertise is defined by the training, right? And so the training has changed and continues to evolve over time on both the trauma and the vascular side. I really hope the American College of Surgeons Committee on Trauma changes that. And I think just by naming the presence of a vascular liaison, that doesn't mean someone who does all the vascular injuries. But what it does do is it creates a pathway, much like ortho and neurosurgery, where you have some tail end ownership of these patients. No matter if Teddy takes somebody back and whether he puts a stent or a graft in the patient, that's going to need to be followed for years. It's got to have a natural history that needs to be established. And trauma surgery is unlikely to do that at your institution. So I think having the liaison in the mix for nothing else than to take ownership of the long-term follow-up of these patients and provide some additional expertise really is what's needed to move forward. But yeah, I have been at several institutions in my military career, moved around quite a bit. And the relationship here is very institution dependent. A lot of personality at various institution drives it. A lot of tradition, which in my mind equates to very thick-walled silos sometimes, can dictate some of these things. And I think that to make generalizations is very challenging. It is truly an institution-dependent skill set and approach to these injuries.
Yeah, and this is a good segue. You mentioned vascular training because that's what determines people's expertise is their training. And you can look at a number of different studies that show this, but one study looked at 2012 to 2022, so a 10-year period of ACGME case logs. And this study found that general surgery residents perform an average of 2.4 vascular trauma cases over their 5 years of training, just 2.4 cases on average. Now, certainly it's different depending on what kind of institution you're in. But this is compared to vascular surgery residents who perform 25 vascular trauma cases over 5 years and vascular surgery fellows who on average perform 22 cases over 2 years only. Furthermore, the acute care surgery fellows who participate in the AAST approved programs have relatively low vascular case requirements. And it's important to note that these are not all trauma cases too. These can be elective cases. For example, AAST suggests 3 iliac artery exposures, 2 popliteal exposures, et cetera, over the course of the fellowship. With that, we'll start, Joe, with you again and move down the line. Does this exclude the current or even the next generation of trauma surgeons from being able to fill that ACS requirement that we have continuous availability of expertise?
Yeah, there's a lot of variables at play here, right? There's the increasing growth of specialization, even within any given vascular group. And Brian could probably attest to this. You've got an aortic person, a vein person, you probably got somebody who specializes in carotid stenting. So even within the field, the expertise continues to refine and hone down to smaller and smaller little subsets. I think the way forward probably is we need to do something about training. I don't have the box on that. I think there are some opportunities to promote pathways where people can, in the same institution, even perhaps pursue trauma and vascular training so that when they come out the tail end of that, they can be the champions at major institutions for vascular injury. And I think we got to think about the injury itself differently. We talked a little bit before we started taping about the PERT team corollary here. For those not familiar, pulmonary embolism response teams have cropped up at a lot of major centers because this is a life-threatening entity that needs some diagnosis and management from a gateway keeper on the front end, optimization, identification. You need some technical expertise to provide around the clot removal that is heavy into endovascular. And then there's a tail end critical care piece. And I think that the correlate here for vascular injury is apparent to me, right? You've got the trauma surgeon as the gatekeeper, and you've got whoever needs to move into the technical phase. In the PERT world, it's cardiology, IR, and vascular, oftentimes interchangeably sharing that call. And then on the tail end, they return to the pulmonologist and the medical critical care team for PERT for their continued care. And I think that the corollary here would be that they would move back into the surgical ICU or the trauma ICU to get care for all their other injuries in the context of their vascular injuries. So I think there's some better ways to think about these things moving forward. And I hope we can work together to embrace some of those opportunities.
Yeah, I agree with Joe. And we've talked about this before. Ultimately, trauma is a team sport, right? I mean, I think the difference is the level of involvement of each separate entity, right? Like trauma surgeons can't manage every single vascular problem, but the degree of which depends on the volume at your center and the volume of your training. At our center, the trauma surgeons do a very large majority of the vascular trauma independently, but there are times when we still need help. And some centers that don't do as much vascular trauma, there's not as many reps for the trauma surgeons. There's probably more involvement with the vascular surgeons there. But the ideal environment is, it's not like trauma surgeons just tap out every time a vascular trauma patient comes through the door, right? I think that's totally the wrong way to do this. We shouldn't just hand over the reins to the vascular surgeons. But I mean, there's something to be said about working as a team, right? Even patients that vascular is going to do a large majority of the case, trauma surgeons should be able to get started and do the approach and, whatever it takes to kind of work together. I think it just looks differently depending on where you are in your center.
Yeah. And Brian, we have a good working relationship at Duke. How do you see it there?
So I agree with everything that's been said so far about how this really is a multidisciplinary process, right? People are frequently not limited to just one injury. And in the polytraumatic patient, I think that the trauma surgeons probably do a better job of kind of seeing the whole field with respect to a patient's overall status. I think the comparison to the PE response teams that Joe made earlier is a good one, and that there are different components of a patient's care, some of which are technical, some of which are limited to a specific injury, but others are much more encompassing of, again, that overall picture. And I think that it's important that both teams communicate clearly and work well together and develop and maintain a good working relationship.
Yeah, we have to acknowledge that that's part of trauma surgery training, the fellowship and critical care aspects of it. You have to take care of the whole patient. That's the whole idea, right? It's the sick surgical patient. The quarterback still remains the trauma surgeon. Joe, do you have any thoughts on this? We hear this, and you've heard it at conferences, and it's like, well, it really needs to be the trauma surgeon who's doing maybe even everything, people might argue. How do you address that argument and even the other side of it when it comes to vascular surgeons being involved in so much vascular trauma and recognizing what that means when you're dealing with a critically unstable patient?
Yeah, it's a challenging question. I think that the practical reality is there will always, for the foreseeable future, going to be an open element to these injuries, right? And these injuries are often, I think about them often as a story told in many chapters. Identification, diagnosis, right? Initial management, often entailing sometimes damage control, because these patients do have a lot going on. So shunt placement, vessel exposure should be in everybody's wheelhouse. And I think there are a lot of vascular trainees, perhaps, that are not as comfortable with that, and they need to get as comfortable with that. They need time on the trauma service and exposure to these injuries to manifest those skill sets as well. But the exposure and control for the open cases, and then the stable blunt cases, which is where endovascular has really made its thing. And I think in some injuries, clearly blunt thoracic aortic injury is an example where it's changed the way we do business for the better. And one could argue some of these junctional injuries are very similar, axillary subclavian, iliacs. Really, those injuries are optimally managed, even long-term, probably with endovascular technology. So how do we marry in these skill sets? Are there some of those skill sets that can be leveraged by the trauma surgeon who's there initially while the vascular surgeon is coming in? So the exposure and the shunt placement, that should be squarely in every trauma surgeon's skill set. And then the vascular surgeon can arrive and you can figure out what you want to do. I would hope together. Everything's always done more expeditiously when you do these things together. You learn, your trainees learn, they observe. And even in the endovascular world, trauma surgeons getting good femoral access, good, solid, reliable femoral diagnostic access, maybe shooting an angiogram, putting a balloon in the right place. Reboa has been beat through the mill in the trauma world, but it's not the only place you can put a balloon to get proximal control, and it can buy time for your vascular counterparts to leverage all the toys that they can bring to bear. And it's important for the trauma surgeons to be in the room and know what the limitations and the opportunities for those toys, those technologies that the vascular surgeon has. So it has to be a team sport across the board.
Yeah. Teddy, when it comes to training, do we need mandates from ACGME or AAST, especially when it comes to training general surgeons? We have ASSET, right? ADAM, even the BEST course. These are all excellent opportunities, but they're not always available. They're expensive. It's very expensive to run these courses, logistically intensive. It's usually a one-time deal. I'd be remiss if we did not plug our very own trauma surgery video atlas, which is not a one-time deal, always available, a handy dandy on your iOS or Android app. In the middle of the night, someone comes in, you need to expose the femoral artery or get to the IVC quickly. We got you covered. But yeah, Teddy, go back to this question on education. If you had it your way, what would you do?
It's definitely a debatable topic. Do we need mandated benchmarks? Yeah, I think you have to. We live in a world where you have to have paper showing that. But I worry that even with these benchmarks, like we all remember what it felt like logging cases, right? Like even if you're the second year resident just riding the bovie, putting it where you're told, you're going to log that case, right? So I do worry that in some training institutions, you're the ACS fellow who's doing a vascular rotation and you're just the guest on the service, right? You're not doing that case. So I am fortunate to have trained in a high volume center where you see what it feels like to get control of a vascular injury. It's totally different than like an elective fem pop. So, I mean, to answer your question in a long-winded answer, yeah, there has to be benchmarks, but I don't know that benchmarks alone are a great marker for competency. I mean, as far as the courses that you mentioned, yeah, definitely. I mean, yes, they are expensive, but I am a very big proponent of asset, specifically Adam. We do those here, even in a high volume center, we do those here because I think it's a good way to train residents preemptively so they kind of know what they're up against when they're in the OR.
And those aren't just valuable for the trainee, it's valuable for the trainers too. Regular reps teaching those courses and getting your hands on the vascular anatomy and cadavers and exposures and a real bleeding heart is extraordinarily important. Now, you mentioned logging cases, but even then, we just talked about the studies that show that people aren't even logging those same number of cases, right? The case numbers have dropped drastically. And Brian, you're Associate Program Director for Integrated Vascular Residency, of which many large academic centers, even smaller ones, now have integrated vascular residencies. And that is a direct head-to-head competition when it comes to the availability of vascular cases. We also haven't even talked about endovascular yet. Depending on what you look at, there's a massive 200, 300% increase in endovascular cases being performed by vascular surgeons from the early 2000s into now, essentially. So there's a big competition there, Brian, when it comes to education. Who gets those cases? Can we get the general surgeons in there to get those cases? Or do the vascular surgeons really need that open exposure for a big open aorta or a fem pop because they're doing so many grams and stents?
Yeah, so I think that's a really interesting point that you raised, and one that's not necessarily given to an easier, straightforward answer. Like Teddy touched upon, the devil is in the detail with any sort of case minimums, right? What is the threshold? What is enough? What is it that gives someone, or can reasonably be expected to give someone competence to do something independently? The biggest area in which this has been of interest in the vascular surgery literature specifically has been with respect to open aortic surgery. If you go back 10 or 15 years, there were very real concerns that open aortic surgery was functionally going to be a lost art and that trainees were going to graduate doing single-digit open aortic surgeries from vascular surgery training programs. Increasing data in recent years has suggested that the situation isn't nearly so dire, that the number of open aortic surgeries that are being done by graduates is not what it was in the 1990s, and frankly, it probably never will be, but that people are having enough of an exposure to be safe and confident and competent with that skill set. The corollary issue is with how do you balance multiple learners, and what is it that people need to expect or can reasonably be expected to know at any given level of training and in any given paradigm. I think, to Joe and Teddy's prior points, that vascular exposure and control are completely reasonable expectations for trainees. There's a lot of nuance in some of the decision-making around reconstruction, but the ability to expose a vessel safely and to stop exsanguinating hemorrhage is, I think, a reasonable expectation for a skill set. So how do you go about getting trainees of every program and at every level the case volume that they're needed to achieve that goal? That's a really complicated question and, frankly, the subject of a lot of ongoing research.
Yeah, and it requires good relations and a back and forth so the trainees get what they need. So, Joe, you acknowledged earlier there's certain injuries like blunt thoracic aortic injury. The endovascular approach is far superior. But with that said, are you worried that vascular surgeons are less prepared for open vascular trauma cases?
I think they're as prepared as they can be, and I think the vascular community is doing a good job to be thoughtful about that as much as you can. The practical reality of endovascular technologies is they're going to take over some of these things. They make them, it's better for the patient. From where I sit, there's ample opportunity still to maintain those skill sets with vascular surgeons from an open standpoint. And we just need to figure out ways, from an organizational standpoint, from a training standpoint, to get the acute care surgeons more in the room at the training level so that they can understand the exposures, how to be good assistants, how to get it started themselves, and all the pitfalls that can occur, which I think is going to be paramount to success.
EPAs, right? This could be a plug for that. You logged the case, but what did you really do? How much autonomy were you granted on that case? How difficult was the case? Having some mechanism, and EPAs being the chosen mechanism going forward for assessing the level of execution on any given case, vascular, particularly for this, over a period of time, I think is going to be very helpful when you talk about graduating residents and what their skill sets are. That's something that's objective and will hopefully at some point, if this is done correctly and followed through, be measurable to some degree. And so going back to saying, well, how do we know that the trauma center has the vascular expertise that's needed? In a perfect world, that might be something that contributes to knowing who has that expertise. Brian, any thoughts? You're an EPA guy.
So I think that EPAs have potentially uniquely nice fit with respect to endovascular work with general surgery trainees. And what I mean by that is that the difficulty of endovascular surgery is not just getting the needle into the blood vessel at the appropriate position and threading a wire and selecting things. It goes into the knowing what the next step is going to be, knowing what the equipment is. The way I describe it to my trainees is that, they may have learned surgery, but now they're learning surgery in another language, and understanding that language and the ability to think laterally and conduct even the basic steps of an endovascular procedure does not necessarily have a lot of one-to-one translation from open surgical techniques. And I think that EPAs are a potentially useful way for us to break that down and break down an endovascular procedure into its constituent parts, and to teach those parts so that way a trainee is able to understand and proceed through the full components of an endovascular procedure.
Joe, there was an interesting survey that was done between some trauma organizations and vascular societies, and they wanted to figure out, what did vascular and trauma surgeons think about vascular trauma and taking call and covering it? And this was done in 2021. And they found that vascular surgeons had greater experience and comfort managing vascular trauma compared head to head to their trauma colleagues. The survey also found that there were more trauma surgeons who felt that they should manage vascular trauma than the vascular surgeons, and that more trauma surgeons would like to incorporate additional vascular trauma into their practice than vascular surgeons. So the trauma surgeons, they want it, right? They want to do more vascular. But the study showed that even trauma surgeons felt they were less prepared than vascular surgeons to do the trauma. So is this whole discussion that we're having and the rationale for even having this podcast just really boil down to general surgeons feeling that this is a lost art for them, whether they're out of training 10, 20 years ago, or they're going through training now and they're going to graduate and say, gosh, I'm a trauma surgeon. I need to be able to stop the bleeding. I don't have as much skills as I like. Is that really what this is all about? Or is it two sides?
Yeah, I think there's two sides of the story. I was involved with that survey, and it was really interesting to me. There's some professional gamesmanship, right? We all do it. We're all surgeons here. I can talk about the ER. They say, well, we don't think those knuckleheads in the ER know how to manage this, right? So we do that to each other too, right? It's very much a sibling arrangement in that regard. Ask any trauma surgeon that you know, what were their 3 best injuries in the last year, and probably 2 of them will be vascular, right? So it is an entity that people are excited about, and it's dramatic. It requires the full spectrum of resuscitation, identification, control, technical elements, back end, rehab, and critical care. But the challenge is, how do we get there? They're excited about it. How do we get the general surgeon there? And the other thing about that survey that was interesting to me was a lot of vascular surgeons, all of them universally felt like they were more capable of dealing with vascular and trauma surgeons. My brain is divided right down the middle, vascular surgeon, trauma surgeon, and I understand that viewpoint. But Brian has probably a very nice, well-organized busy elective schedule. And when you throw into the middle of the night on a fairly regular basis an all-night case that takes a lot of time, and then throws out his whole elective schedule, because a lot of vascular surgeons are aortic centric or carotid centric, as I mentioned, right? So they have other practice interest areas, and we're robbing them that. I think if we can find a way to partner, we alleviate the burden on the vascular surgeon, but we utilize their technical expertise that the general surgeons are having a hard time maintaining for the older groups, and to even grow for the younger folks. And all underlying this is variables that we're not even going to talk about, like the proliferation of trauma centers, right? It's not that we see fewer injuries in this country, it's that they're dispersed across a broader spectrum of HCA hospitals. And I'm not slandering any organization, but that's just the reality of what it is. So the reason some of these numbers are down is because trauma care has been dispersed a bit more and decentralized. And that's another challenge we got to think about.
Yeah, that's been proven. There's a study looking at XLAPs, right? Major XLAPs in trauma centers. And depending on whether you're low, medium, or high volume for XLAPs, and I believe it was 10 or 12 laparotomies a year was the cutoff for low volume. Just like a lot of different types of surgeries we do, the more you do, the better you are at it. And outcomes are better when you do it more often.
Hey, Patrick, can I ask a question of Teddy and Brian? So, Teddy, does everybody in your group feel equally comfortable and passionate about managing vascular injury operatively?
No, I think some of our group members don't have as much interest or the skill set, but we are fortunate enough that we have enough redundancy in our schedule that there's always someone in the group.
Sure, UT Houston's a different monster, but I would say probably any institution you're gonna say some. And I bet if I asked Brian, how just do all of your partners universally jump out of bed and rush to see what's clamoring about in the front yard whenever they get called for a vascular injury?
So we have a bit of a unique model in that regard at Duke, in that we have 4 hospitals within our health system, and there is an opt-in element to the management of acute care coverage of the level 1 trauma center that we have. So there has been a selection of the faculty that are interested in and really motivated by that acute care vascular surgery coverage, both in the setting of management of trauma, but also in the setting of the other acute care vascular issues that we might encounter.
Well, and both of you are being good stewards of your institutions and saying our institutions are awesome. I've been at many, and not all of them work that way. There's some vascular surgeons are into it, some trauma surgeons into it, and then on both sides, the other people run the other direction if they can. And so I think the way to move forward is to pull the Teddy Puzios and the Brian Gilmores of the world and put them on some kind of response team for these vascular injuries. Then you're going to see the way things can be done and should be done personally.
Yeah, and ideally you have enough overlap in your call schedule that you can create that without destroying the rest of your home life, your elective life, et cetera. And that seems to be a challenge, right? There's only so many folks in each group, and in general, you're operating on the razor's edge in terms of one person gets sick or needs to go out for some time, and then all of a sudden you're double covering, and it can be quite challenging. I think that's probably not unique. In terms of this issue, we don't have a great answer. We all agree that we need to pay close attention to it, and that there's no one size fits all to the problem. And without a doubt, trauma centers need to do their best to enhance collaboration, to figure out what works best at a single institution, and for any given patient to do what's right for that patient in front of you. You have to be ready to offer unique solutions and understand what resources are available to you. And oftentimes that may be a vascular surgeon if you're a trauma surgeon, or a unique endovascular approach if you have that luxury. So no one owns vascular trauma. No one owns it. But are there any additional, more specific solutions we can recommend that are more than just everyone get along and do the best for the patient in front of you?
A lot of your audience is probably trainees, right? Who are listening to this. And some of them are saying, I want to get better at vascular injury. How do I do that? I think you have to take a lot of personal ownership of those opportunities. You need to go knock on Dr. Gilmore's office and say, you got some cases I can assist with, or get in the OR, do those things. The skill set acquisition, as we've talked about with the GME case requirements and even the EPAs, it's not built into the system. You've got to create your own pathway if you're truly interested in improving in this specific area to some degree, right? You're not going to finish 2 cases and be a pillar of vascular injury care if you're your institution. But if you build that skill set through means that you have to get creative with, and you build a network. So when you move on to your other institution, you call Dr. Gilmore, hey, I got this vascular injury. What do you think? And there's I don't have a vascular surgeon here, or I don't have one that I feel comfortable with. Now you've got a network of people working on a problem that's really challenging. And I think that would be really cool.
I do think it's an important thing for us to continue studying in terms of what the volume outcome relationship is with respect to individual surgeons and with specialties. I think that this is going to be a moving target, not just with respect to what individuals do well, but what the trend in management winds up being over time, particularly as some of the older generation who may have more experience with and comfort with this management phase out of their careers and retire.
Patrick, can I go back to one thing? I would say you should be in charge of your own education. One of the things I remember from my residency training, I was at a place that didn't do a lot of vascular trauma, but we did do a lot of fenestrated endovascular cases on vascular. And as a resident, that was not a junior level resident case, right? Like no intern or second year wanted to be in there for all of that. But I can tell you that every time we had an open exposure to start that case, I made myself available. And so I think if you can tell your faculty and your fellows that like, hey, I have an interest in vascular and I want to be a part of whatever components that are helpful for you, your skill set, and that may advance as you're in residency.
Yeah, and particularly for the general surgeons listening, what we talked about earlier, exposure and control, that is the key. Certainly you want to do more if you get the opportunity. Last question, this is for you, Joe. How many dual trained vascular and trauma surgeons are you aware of in the United States? And what was your pathway briefly, and would you recommend it?
I would not recommend my pathway because I did everything through the military. So I wasn't going to make any extra money doing anything. I won't go through the math of the 20 years that I owed, but it worked out really well for me to do a vascular fellowship. And I did it after 6 years of being a trauma surgeon. And it was because I could see all these cool injuries being done endo by Brian, and his crew. And I was like, I want to be part of that crew. And the military was very keen to have one. Before, they would have to deploy a trauma surgeon and a vascular surgeon. And if I'm one guy with both skill sets, I save them money, I save them exposure. So they were very keen to let that happen. That being said, there's probably, I think we did a straw poll and came out to like 13, but there may be 20 or so people who've done both trainings, but the majority go on to do not both in terms of clinical practice. Some vascular surgeons I know, or you wouldn't even know that they had been trauma critical care trained. It's not part of their identity. And there are a few that have gone the full trauma route, and maybe they just do a few more angios than normal. But the people who are dual practicing, I know 3 in the country. I wish there was one at every major level 1 trauma center personally, because I think they would be tremendous liaisons between the two worlds and do much to break down the thicker silos where they do exist.
Yeah. All right, fantastic. Well, thank you all for joining us today. And, this is a problem that we'll need to continue to keep close eyes on and do everything we can to get the next generation ready to stop the bleed and save some lives. Until next time, dominate the day.
This episode of Big T Trauma was sponsored by Teleflex, a global provider of medical devices. Learn more at teleflex.com.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple iOS and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.